science. It was also hosted by Washington University in St. Louis, which is where we all met. And so that's a picture of all of us in training. In addition to training together at this site and having D&I as an interest area, we both were mutually interested in adapting evidence-based treatments to help children in rural settings and sort of really figure out how to get the best stuff that our field has to offer into real-world settings. And that kind of started a conversation between us and got us kind of to where we are today in terms of collaborating and continuing to try to bring ideas from dissemination and implementation science to different audiences. We definitely want to acknowledge that a lot of our training came from this TIDER experience, and much of the information that we'll share with you today was just adapted from the work that others have done, and we've acknowledged those folks in our slides today. We kind of came to this. I'm trying to figure out how to forward my slides here, and it's not. Oh wait, let me try this one. There we go. We came to this study of D&I through sort of different pathways, and mine started in 1998 when I was working in a rural Nebraska pediatric primary care clinic as a psychologist. It was my first time to work in integrated care, and also my first time to really try to get my mind around population health. I was trained very traditionally in psychology and thought that I could just, implement the usual treatment the usual way, but it was very striking to me how little a need I met and how little my skill set was utilized in these settings. I really needed to think more creatively, think about how to work faster, think bigger, and most especially figure out more creative ways to translate evidence-based treatment so they actually got to more people. I worked in a very traditional manner the first few years that I was at the clinic and often had an 80 to 100 patient waiting list. So there was a real demand there for thinking about how to make this stuff happen. This is a picture of me in 2000. At that time I was especially trained and kind of had a strong background in ADHD. And one of the things I was picking up on in clinic was that the practice was going on instinct and making that diagnosis in spite of the fact that we had 20 years of really good research on what works best for kids with ADHD in terms of assessment. And this practice had created some of their assessment measures themselves. They were using some weak measures, and I got the idea at this time that maybe one of my roles in working as a staff psychologist was to help them develop a way to keep up with the evidence base in assessing for ADHD and other kinds of things. In other words, I had originally thought of myself as someone that just needed to see patients on a case-by-case basis and do research on problems that were kind of germane to clinical psychology. But suddenly I started to see that there's this bigger role for me in this setting, not just as a program developer, but also as a researcher. And so here's one of the first studies I did, and it gives you an example of what kind of like a very primitive D&I style study might be. I looked at all of the things that our practices, there were a couple of them, were doing to evaluate ADHD. And they said that they had an internal, in-house sort of protocol that they were giving to all the children who came in for ADHD assessment that consisted of these measures. Now, the parent and teacher CLAM are semi-evidence-based, but the TOVA has since been proven to not have good evidence, and at that time was pretty questionable. And the parent and teacher checklists that they used, they made up themselves. So those were obviously not evidence-based. But even though this was their clinic-wide packet that they gave to quote-unquote all kids presenting with concerns about ADHD, you can see they were only collecting these data in about 20 to 30% of their patient work. I also looked at whether they were using any really good, like widely recommended evidence-based tools. And at pre-protocol, before we did anything with these two practices, you can see these measures that are evidence-based and kind of well-recommended were not being collected at all. So essentially what we did was we trained the practice to collect these data reliably. We looked at the system of care. We looked at how things moved through the office. We looked at who was best for what. We trained the providers on how to interpret the measures. We came up with a really savvy way of depicting what all these different measures show so they wouldn't have to page through thousands of rating scales. And we kind of implemented a office-wide evidence-based assessment strategy for ADHD. And a couple of years later, we did this follow-up piece. The light blue bars show their follow-through in collecting evidence-based measures at 1 year after the training, and then again at 3 years after the training. I didn't put a reference on this, but we published the study in Pediatrics, which is a widely read clinician-focused journal for pediatric primary care. And I guess this just shows, this is data from 2001, then again 2003, is that we weren't so interested in studying, did this assessment strategy work? Did we accurately identify kids with ADHD? Not so much. We were more interested in the fact that it could be implemented, that it was feasible for primary care clinics to collect these data, and that we could help support this clinic, a couple of clinics, in seeing that they were doing this right, but that also our data were interesting enough to be published and generalizable to a larger audience. So this little kind of study gives you a very simple, sort of rudimentary implementation style study. It gives you a flavor of kind of what we'll be talking about today. And when I was preparing these slides, I didn't think of this. Well, I thought of it actually just a little while ago as I was looking over them. I presented this data. I got selected to do a different NIH training in 2005 called CHIPS, which is Child Health Intervention Prevention Services Research. And I went to this fellowship. It was a week long. The first day that we were there, I had to present the study I was doing. I presented this data, and the folks from NIH and the other faculty that flew in from around the country to provide consultation thought this was really cool data, but they kept insisting that I needed this theoretical model, and I couldn't go for NIH funds until I had a theoretical model, and there was no theoretical model for how to explain like how this adoption happens, or how to make it happen, or how to implement something, quote, the right way or the best way, or any of this. How to make these results usable or transformative for the field and not just the clinic. And that was in 2005, and I think D&I science was really in its infancy at that time. Now there are models, and explaining all of this and guiding researchers on how to do this kind of research and make it meaningful, and that's what we want to talk to you more about today. And I'm just going to take a quick break here because my little pod disappeared, and now it's back. So I can't see if questions are popping up or anything. So let me just relaunch my slideshow. Okay, much better. Now I've got it all. I'm in total control now.
Jodi, this is Polly. If questions pop up, I will. I'll forward those to you.
Okay, and I knew that you were doing something with that too, so that's good. Okay,
great.
So we've started already giving you a flavor for what we're talking about, but here's like the kind of overview. We're going to talk a little bit about a rationale for a new science, this D&I science, give you some definitions. Then Tina's going to talk about current issues in D&I research, resources and opportunities, and then I'm going to end the call with just a slide or two about my most recent thinking on the subject of D&I within CFHA. So that is what you have to look forward to. My first slide is kind of hilarious. It's called The Unfinished Bridge, and again, like just before I started this presentation, I was looking through my slides, and I'm like, but I chose a picture of a finished bridge. Now, why did I do that? So you have to imagine that this bridge is not finished. My preference is that you envision the right-hand side of it as unfinished, because that's how it's going to be laid out in just a minute here. What I want to say is that, this example I gave you sort of gives you a little kind of data example of what D&I science is about. But I also want to give you sort of a metaphor, and this unfinished bridge metaphor is what I like. It's sort of like our science has developed to a point like an unfinished bridge. It's elaborated, at least for sure, on this side, where we have really good type 1, some people refer to it as type 1 research, and there are different there's different language around how you categorize different types of research, but we've really done a pretty good job of coming up with a structure based around basic knowledge in health and mental health. We've done a pretty good job figuring out what works and doesn't work, and one of the most popular things in the field of psychological science has been randomized controlled trials showing, hey, this treatment is really effective compared to this other treatment or control group, and that's great. My field is ADHD and child externalizing behavior problems. If I had to pick a specialization besides integrated practice, that's what it would be. And whenever I have a kid that presents to myself or to a trainee with unruly behavior, disruptive behavior, noncompliance, I'm always really confident that we can make a difference. There have been good scientific studies of parent behavior management training that expand over 50 years. It's a very strong area of inquiry and research. If you look at some of the meta-analytic studies that have evaluated all of the research, you see some of the strongest effect sizes in our field that, like, we know what works. We can fix these kinds of problems, and that's it's a pretty big bragging point. The problem is that we haven't spent as much time figuring out how to actually make sure that those treatments reach the people at the end point. We haven't really worked very hard to incorporate the views of patients or stakeholders into our science. Among other things, the net result is that we have treatments that are hard to disseminate, don't fit into the environment where they are needed, or they're just not really well liked by consumers. And if you think about parent training, as I was just talking about as an example, they're designed to be 8 to 10 to 12 session long sessions. Some of them are designed to be administered in groups. If you look at the data on how many times people attend parent training groups in the real world, it's 3 sessions. That's 3 sessions out of the 8 or 10 or 12 that the evidence-based treatment requires. And so we would wonder if they benefited at all from the treatment if they only came a couple of times. It's true for in-clinic based parent training as well. So we know that what we've got is just not really portable. And D&I research really focuses on that question. How do we make it portable? How do we bring it to the endpoint? Adapting it as needed, and then studying how it gains traction. This is true not just for specific treatments like behavioral parent training like I'm talking about here, but also for service delivery systems. So looking at how, for example, a model of integrated care might be disseminated, or how it might be implemented in, say, a federally qualified health center or other kinds of settings. So, so that gives you a sense of sort of my metaphor. Another way that I like to think about D&I science is in terms of this equation, which I stole from Miller, Munoz, and Christensen. They presented this at a conference I attended a few years ago. The idea that if we want to have public health impact, we have to consider not only effectiveness, but also reach. And our fields, this is true for the medical field, and it's true for certainly psychological science and the behavioral health field, has really focused very hard on effectiveness, but not very much on reach. And so that's kind of where we're trying to go. The net result of, kind of that lack of focus on reach is that we haven't really developed good science at that far end of the bridge, where it reaches the land. There's we know a 20-year lag between when something is demonstrated as having good evidence base and when it actually makes it into the trenches. So, for example, when I was in graduate school was when the first good studies of parent-child interaction therapy were coming out, a parent behavior management program, and it was, identified as an evidence-based treatment that long ago. And it's just been in the last couple of years that like the community mental health programs in my area here in East Tennessee are starting to like teach their clinicians how to use PCIT. It's 20 years. Another issue that we've had is siloed research and practice. So, you know, psychology has its research and its own journals and its own readers and its own methods. Public health is in a separate silo. Medicine's in another silo. Social work is in another silo, etc. We know that even the way in which we fund research sort of is flawed and contributes to this problem. We know that for every, well, this is actually a study that was done in which they looked at some sort of probability modeling, and about 33 R01s are funded for every one like really usable study, something that really can get traction. So the way in which these R01s are being written and developed are not, do not have the endpoint in view. Part of that is next bullet, lack of consumer input. And then finally, you know, this issue with R01s, a lot of these larger studies are long-term trials, like 5-year trials. They can't keep pace with technology or the healthcare evolution. Technology is an easy example. You think about developing, I've seen this happen, developing a YouTube intervention. And by the time you do all the trials and studies and it's 5 years later, it could be even longer than that if you think about rewriting your proposal and getting accepted and getting the funds and all this stuff. By the time you roll out your results, there's, you know, iPads and iPods and all these smartphones and other kinds of apps and things that really are a little slicker than YouTube, and you just couldn't get the research done quick enough. Some interesting other information that fits with this. This was a recent study by Bronson, in which they asked researchers, of the methods that you use to disseminate your research finding, which do you think has the greatest impact on public health or medical practice or policy? And these are the top 4 things that researchers listed. So, you know, researchers are number 1 going to journal articles to disseminate their research findings. But when you ask practitioners the same question, like where do you get information that impact your practice, they're not listing journals. They're listing professional associations and seminars and workshops. And I don't know how many academics we have on the line, but you know, this isn't how we get promoted and tenured, right? By doing talks at seminars. And so there's this huge disconnect in terms of like how science and practice are relating to one another. One of the interesting things that I think is also related to this is reflected in this slide. The Institute of Medicine put out a report on learning healthcare systems in 2012, and they've depicted this kind of, this whole thing that I'm talking about in a much more kind of pragmatic and service-oriented way, where you have like science being translated into the evidence base, and you know, that process being poorly managed, and you lose a bunch of information, and then the evidence, and that could, you know, that could come from siloed practices, or the way in which that information is published in journals instead of being translated to seminars or workshops. Then you have, you know, the evidence that's translated, and it's not readily available or portable to a real care setting. So you kind of like lose a bunch of more stuff, opportunities. And then you have, you know, the actual care itself and how it's experienced by the patient. And again, opportunities there to lose information. So, you know, where our science and where our patient experience are really in 2 different places. And so I hope that all of this has provided you with a good sense of the rationale, and it may be easier now for me just to provide you with 2 easy kind of short definitions of dissemination and implementation. Implementation refers to introducing new practices or change in a way that gains traction and follow through in the real world. and then dissemination. How information about mental health care interventions is created, packaged, transmitted, and interpreted among various stakeholder groups. What I'm going to do now is pass the screen to Tina to talk about more the technological side of the science and how how it happens. So.
This is Tina, and I'm eagerly awaiting.
I know, but I'm eagerly awaiting for my brain to tell me what I'm supposed to do again. So I'm clicking on Change Presenter, and I'm making you the presenter. Is that right? Polly, are you on?
Yeah, yes, that should work perfectly.
Okay.
Tina, do you have it yet?
Oh, there it is.
Okay, perfect.
Okay, and then I'm going to click Show My Screen. And then someone will tell me if you can see.
It looks good.
Does it look good?
Uh-huh.
Okay, great. Okay, so this is Tina Studts. I'm really excited to talk with you all about this topic, and Jodi did a great job introducing the rationale and some definitions. So I'm going to move to some current issues in D&I research and then talk also about some resources and opportunities in this area. So clearly, the importance of D&I research has kind of finally been recognized. But as Jodi alluded to, it's still a new and developing field, and there are a lot of areas for growth still in D&I research. And I'm going to talk about some of those right now. Let's see if this works. Uh-oh. Okay. Did it change?
Yes.
Okay. So not only are interventions not self-implementing, so anyone who has actually delivered an evidence-based intervention or supervised people who are supposed to be delivering them or who are researching the effectiveness of interventions, we all know that they don't implement themselves. Somebody has to actually deliver them and be trained and figure out how to do it. Not only that, but the implementation strategies themselves are not self-implementing, meaning you can't just develop an intervention and expect people to come running and get it and start adopting it and delivering it in all of their sites. What we need are that people in the real world, like patients, practitioners, administrators, policymakers, they need to know what works, and they need to kind of have some sort of interest in the effective interventions, and then the tools and resources to know how to get them into their practices or their healthcare agencies or their regions. So researchers who live in these glass houses who are always talking about fidelity and how well you develop and deliver the intervention really shouldn't throw stones. So just because you develop it doesn't mean that it's going to actually be adopted and delivered in the real world. So leaders in this D&I field have realized that to get effective interventions out there, you actually have to disseminate and implement strategies to disseminate and implement the interventions, which is sort of a meta concept. But that's sort of what this presentation is all about today. What I'm going to talk about first is this concept called the 5 R's, which is from some ongoing work by Peake and Kessler and Glasgow and others who have looked at what kinds of evidence are most important in D&I research. There are going to be 5 R's, and I'll talk kind of briefly about each of them. So first, we want research which is relevant, which is rapid and recursive, which is rigorous, that makes resource needs explicit, and that can be replicated. First, relevance to stakeholders. So when we talk about stakeholders, we're not just talking about academics and researchers who often research and publish things for themselves and get promoted and tenured and all of that kind of stuff. We actually care about research that gets out to the people who need it, like policymakers, patients, practitioners, and administrators. So there are a couple of different ways to think about the relevance of research in this D&I field. One is that the consort people have come up with this pragmatic explanatory continuum indicator summary, which looks at 10 characteristics of studies and puts them on this continuum, each of these indicators, from an explanatory type of study to a pragmatic type of study. Things that are relevant to stakeholders tend to be pragmatic. So if you've ever been pressured to deliver an evidence-based intervention based on 2 or 3 journal articles and said, but this has nothing to do with my setting or my patient population, or look at these inclusion criteria, they only included this one little group of people, that would be an explanatory study. And to convince people to actually deliver interventions in real-life settings, we need more pragmatic types of evidence. So flexible interventions, we need loose kind of criteria for people to be in the study. We need compliance to be more real-world compliance than controlled RCT compliance. Second, we can look at this continuum of research and the degree of involvement with stakeholders. So if you think of research as occurring on participants, clinics, patients, communities, in patients, clinics, communities, or with patients, communities, and clinics, we're interested in the right side of this continuum, which kind of gets toward the community-based participatory research and the kinds of questions that PCORI is interested in answering. So we are not so interested in conducting these tightly controlled studies on a defined population, but actually joining with stakeholders right from the beginning in determining what questions we need to ask and figuring, and they're part of the process all the way through dissemination and implementation in all sorts of settings. Next, we need to look at speed. So how can we speed things up to be rapid? So Jodi talked in the first couple of slides about the 20-year delay of getting research findings into practice. So traditional RCTs are part of the reason that we have this. So we need them to demonstrate efficacy and effectiveness of interventions. But the goal of something called a pragmatic or practical clinical trial is to actually improve practice and inform clinical and policy decisions, not to determine the effects of the treatment. So the example she gave us where can you take this evidence-based assessment for ADHD and implement it in your clinic, and we're not going to look necessarily at the outcomes of those kids with the ADHD. We just want to know if you can actually improve the practice by implementing this procedure or this protocol. Those are the kind of questions that practical clinical trials will often answer. So the goals are fundamentally different than what an RCT will test, and then what follows is that the design, participants, measures, and results, all of these other characteristics of the studies, are also different because they follow that goal of improving practice. So the goal isn't to determine the effects of treatment. There are other interesting kind of designs that are used in this kind of study, like hybrid designs where you can actually look at effectiveness and implementation at the same time to try to speed things up and get those results into practice more quickly. There are adaptive designs like SMART designs and stepped wedge. There's all these just clever ways that you can kind of make things happen more quickly and be more flexible, and then take those results from kind of a quality improvement perspective and get them into the real world more quickly. The next R is rigorous. So some of you may have seen this very exciting article from 2003 before, which is a systematic review of RCTs of parachute use. And the authors had to conclude that even though parachutes seem to reduce the risk of injury after gravitational challenge, their effectiveness has not actually been proved. So even though in intervention research, the RCT is king, and RCTs are kind of the gold standard, they're not always possible or even necessarily desirable in D&I research. So things like natural experiments and quasi-experimental designs and case studies, these kinds of research can also be extremely informative. What we need for our research to be rigorous is for it to be robust and generalizable, not necessarily for it to be a randomized clinical trial. And so we need to see convergence of results. So the more people who study how to get effective interventions or protocols or practices out into healthcare settings, even if they're using a variety of different designs, if we start seeing convergence of results and findings, that's the kind of rigorous research that we need. Next is resource needs, which I'll talk about in a couple of slides again. So resource needs are important because money talks. You can't overlook cost estimates, and at a minimum, your policymakers, payers, and practices need to know the cost associated with implementing an intervention or a procedure or a protocol or a policy before they'll even consider any change initiative. So these two slides are from a presentation that Jodi did last year at CFHA, and I was in the audience, and as soon as she and her graduate student were done presenting it, everyone in the audience wanted a copy of this talk. And since then, I know that other people have asked for copies of this talk. Basically, she was showing that in this primary care clinic, if you had a behavioral health consultant utilized, then the primary care provider spent less time with each individual patient. and yet the amount reimbursed by insurance was no lower. And so basically the primary care provider had time freed up to see more patients while the behavioral health consultant was in the clinic. This is the kind of information that like speaks to people. If somebody sees these two slides, like people in the audience did that day, they want this because they know that this will be convincing and help convince the administrators, the policymakers, and those in power that they can actually take this plan and implement it in their own clinic and have the kinds of outcomes that they want. So money matters and time matters, and these kinds of resource needs are really important to include in research. The last R of the 5 R's was replication. When you're using different designs, and we talked about the rigor earlier, one way to build confidence in findings is just to replicate them, especially like with the same design and with different designs, so that you actually get confidence in different types of evidence. So people like me who were trained in RCTs and kind of brainwashed from an early age that RCTs are the only type of study worth conducting can actually be convinced over time that other types of evidence are especially relevant to this kind of question. You can't always do an RCT. And so if you can even get case studies that are replicated, or observational studies, or simulation modeling, if you have quantitative and qualitative data about things, about implementation and dissemination, if you have natural experiments, all of these things can converge across diverse methods and lend support or help us understand better how to better disseminate and implement our evidence-based practices in different settings. All of this leads to 9 kind of recommendations about where D&I science needs to go, both from an academic research and a practice research framework, and those two things should be partnered all the time. So this is from a talk that Glasgow and Raven gave at CRISP in Denver, which is a resource I'll talk about in a couple of slides. These are basically 9 recommendations. The first is that stakeholder perspectives are crucial, and so that includes the end users of whatever it is that you're trying to disseminate and implement, patients, practitioners, the policymakers, et cetera. If you don't consider their perspectives, then basically you're just banging your head against a wall. So we need work on how to communicate research findings to the target audience in a way that they understand. So the data, or a way that they appreciate, they may understand it, but for them to buy into something, sometimes it's subjective indicators or anecdotes that speak more loudly to policymakers and non-scientists than the data that we're kind of used to, the data language we're used to speaking in. Second, we have to design for dissemination and sustainability. So this is for people who are developing or trying out, trying ways to get a new evidence-based practice into their setting. So Brownson did another kind of cool study where he looked at public health researchers who were doing intervention research and found that almost 3/4 of them spent less than 10% of their time on dissemination. So all this work on developing interventions and then less than 10% of the time getting those interventions out there. And 2/3 of them didn't really involve stakeholders in these efforts. So the very people who they're intended for didn't even necessarily know about them or weren't involved in the interpretation and dissemination of findings or interventions. The values were lower for NIH-funded researchers, but higher for CDC Prevention Research Center researchers and those with practice experience, which kind of links to the importance of the practice research partnership. Third, it's important to consider the multi-level context of real-life healthcare settings. So we've got individual, interpersonal, organizational, regional, policy level, historical, and time. And none of these things can be ignored. It's complicated. So collecting data at all different levels and using repeated measures, and if you have a statistician, some kind of mixed models for analyzing outcomes, all of these things are really helpful and informative in D&I. Fourth goes to the question of when people look at a research, like an article, and say, well, this doesn't apply to my population or the people that I work with. So external validity is really important. And we need to be looking at how well findings generalize across patient populations and different staffs and settings and policy contexts. The fifth is about resource and cost issues, which just gets hammered home every time, that costs are both money and time, and one gain for someone might be a loss for someone else. So you have to be keeping the big picture and looking at the perspectives of all different stakeholders when you're looking at making a change in a practice. Sixth is adaptation. So everyone kind of knows that when you deliver an evidence-based intervention, fidelity often slips. And often it's treated as this dirty little secret and people don't want to talk about that. But we all know that adaptation happens, and so we need to understand it. So document it, and we need to write more about it and learn more about it and how adaptation, local adaptation especially, affects outcomes. Seventh is the issue of complexity, which just can't be ignored, because every practice change that we make has intended and unintended effects at multiple levels, and we need to be able to describe what those are so that we understand more about the effects of implementing evidence-based interventions in any kind of practice. Number 8 is about completers, and so this goes back to generalizability. So often, outcomes research or intervention research will report, maybe they'll do intent to treat analyses, but they'll report about completers or those who enrolled in the study. But that's only the top of the fraction. So when we look at a population health model in healthcare, if you're in a primary care clinic or a health center, we care about the bottom too. Who didn't participate in the intervention, and why not? So we are trying to reach the largest number of people possible, and we can't ignore all those people who never even know about or demonstrate any interest in receiving an intervention. So it's not only the top of the fraction we're concerned about, it's the bottom as well. And then the last one is that models, methods, and measures for dissemination and implementation research have to be practical and explainable, interpretable, and actionable for all stakeholders. So what's tricky about this, Jodi mentioned this earlier, is that there are actually over 60 existing models for D&I research. And so it's actually kind of confusing. There are certain aspects in common across multiple models, but there is some muddle in there. And just as in any kind of research, models and theories and frameworks are important because they help make sure that you include essential components in your research or your questions, that you can interpret your findings, but mostly that you have a systematic structure for moving the field forward. So the catch is that right now in D&I science, when it comes to implementation strategies, they're probably one of the least well-defined and described aspects of implementation science, which is pretty ironic because implementation strategies are the intervention and dissemination and implementation science. So we should understand when you look at what Jodi did in her clinic to get the providers to start using this protocol, this assessment protocol, what were those strategies? Like, how can we characterize those strategies, and how can somebody take those strategies and use them somewhere else to improve practice in another clinic or another setting? So what's left that we need to look at in D&I is to figure out what exactly has to be assessed, how frequently and for how long, and with what kinds of instruments. So I'm not going to dwell on this one too much because I want to leave some time for questions at the end. But measurement itself is a question. If you've ever tried to measure the types of things that we need to measure to figure out dissemination and implementation outcomes, this is what you get if you Google cacophony and look in images. There's a lack of harmonization of measures. There's so many models and so many people are trying to measure things in different ways. It's a little bit overwhelming. So luckily, there are 2 big projects underway to streamline this process. One is SARC, or the Seattle Implementation Research Collaborative. And there are going to be a couple of websites in the next couple of slides that if you access this webinar after it's over, you can go in and look at all of these different links that I'm going to give you in a minute. But SARC is basically trying to go through and provide a comprehensive library of instruments to measure at all different levels all the types of variables that we think are going to contribute to how well we can implement and disseminate evidence-based interventions. Another is the Grid-Enabled Measures Database from NCI. So they have a D&I initiative at GEM, which uses a crowdsourcing approach, and lots of people who are doing D&I science are going in there and filling in what measures they use to look at like the team qualities and the readiness for change of their organization and all those kinds of variables that we think are associated with dissemination and implementation outcomes. Finally, I'm just going to show you these 2 slides. I think it's 2 or 3 slides, and pass it off to Jodi again. If you're a researcher or you want to partner with a researcher, this slide is just to show you that there are a lot of opportunities for D&I funding if you want to do funded research in this area, including NIH funding and PCORI and CDC and the Robert Wood Johnson Foundation. There's also lots of national and local CTSA translation projects. There's actually an NIH standing study section which focuses on dissemination and implementation research in health. And this is a list, 2 slides of excellent resources that I would encourage you, if you're interested in this area, to download this webinar when it's posted and access as many of these as you can, because you will basically see a wealth of resources that are being developed for all of us who are interested in this area to access. And now I'm going to pass it back to Jodi.
Now I should be unmuted. Can you hear me?
Yeah.
Okay. And I'll just talk about just some preliminary thoughts I've had about this field of D&I and the Collaborative Family Healthcare Association. Tina and I both are on the Research and Evaluation Committee for CFHA and spend some time thinking about the role of research in this organization and how to grow that role and how to how to disseminate dissemination and implementation science. So here are just a few thoughts I've had. This is going back to that IOM report on learning healthcare systems. They put this nice looking graphic together that shows what a learning healthcare system should look like. And instead of having science and evidence and care as this linear process that sort of falls off at each juncture, it's this coordinated model where everything is sort of coexisting, which sounds great in theory, but it's kind of like, you know, can you tell us how to do that? And so I guess, let me just back that up. If you look at this model and you think about where academic scientists are relative to this model, they're not really very close to care, right? So they're in the science circle, but they're, you know, kind of far away from maybe the care part of the circle. And while being an academic sort of research-oriented person, that's what you do full-time, is useful and has its value, it doesn't place you closer to that kind of central piece. It doesn't really epitomize what they're trying to get at here in this model. And I kind of feel like the membership of CFHA are better positioned in many ways in terms of just actual day-to-day being in the trenches and being involved in healthcare decision-making and policy and patient care. They're better able to kind of straddle these 3 circles than maybe perhaps partners that are more strictly engaged in research. And so there are sort of like kind of different roles that these different people who are interested in D&I science can play in thinking about this learning healthcare system model. So when we're disseminating and implementing D&I science, we're thinking like, who are the community of stakeholders that have the interest or the skills to serve the science or evidence role in a learning healthcare system? And I'm just sort of making the case that CFHA has a lot of members that are really proximal to that system. What is the range of skills and expertise among this group? And it's different than it is for people who are very traditional academic researchers. And then how can the best D&I methods be adapted? And I would also add, how can the best D&I training be adapted to equip this group? So, you know, Tina and I are both full-time academics. We both do academic work that brings us into this circle, not as closely as, for example, students that I've graduated or students that I train, but we were trained through TIDER, and TIDER was great, and I introduced that at the beginning of my talk today. but TITRE is developed for people like us who think and have these skills and abilities and time the way that we do. And so what really needs to happen is for TITRE training, and there's other kinds of training like TITRE, it's not just TITRE, the journals that go along with implementation science and some of these other resources that Tina showed earlier need to be adapted, I think, for a more in the trenches kind of research that allows some of this community of stakeholders within CFHA better access to training in D&I science and training in a kind of D&I science that fits what they can do in the trenches, much like I was when I did that little study that I showed you at the beginning. And so these are just some kind of preliminary thoughts, and I've been in conversation with some of the people doing some leadership in D&I research and Bethesda at NIH on kind of looking at adapted models for training folks to do D&I science and bringing that kind of training to have better traction within our community of stakeholders. So that's kind of the future, perhaps. Those are all of my comments, and I think I just have one little slide at the end so you can remember what we look like, and if people have questions, we'd be happy to answer them. That was fun.
Wonderful. Thank you, Jodi, and thank you, Tina. That was a very thought-provoking and informative webinar. I'm wondering if anyone in the audience has questions. As we mentioned earlier, if you do have questions, there is a control panel on the upper right-hand part of your screen that has an area where you can type in questions, or you can raise your hand and I'd be happy to unmute you and you can verbally ask the question. There is a question, can we go back to the resource website slide? Jodi or Tina, can you guys toggle back to that particular slide for us? And yes, and as a reminder, this presentation is being recorded and will be housed on both the CFHA website and the AHRQ Academy website if you want to refer to it in the future. So we should have that up probably in about a week.
I would also say if you're in a big hurry, you could email either of us. We could copy and paste those and send them to you in an email.
That's perfect.
Emails are on the slide.
Very good. Guys, we have another question. What recommendations do you have for early career professionals looking to start a line of research in primary care?
That's a great question. From my own path, the way to do it is to utilize existing resources. So primary care-based research does not cost any money. It's very interesting. You can do really cool studies like that one I showed at the beginning, and I think it's a study that has huge impact. We didn't have a grant or anything for that. We had students that wanted to train in primary care in a clinical capacity, and we just wrote it into their contract that they had to spend, like, they were going to get 8 hours of clinical training and 2 hours, and they had to do 2 hours of chart reviews and help us pull all this data. And so and they were happy to do that because they were master's level students in a local graduate training program, and they pulled the data for us, and we were able to publish some studies, and that was really helpful when I did go finally to apply for research funding, which, as you know, is competitive. The other thing that's been helpful to me personally is internal institution grants. So I've had a couple of small seed grants from within my university to fund some of the projects that I've done as well.
And I would add to that, this is Tina, so I've done a few studies in primary care, and like Jodi, before I became a faculty member, I used to work in a primary care clinic. And I think the two things that were most helpful to me, first was having a buddy in the primary care clinic, hopefully somebody with influence. So first of all, the director, but also a nurse or someone who is really on board and interested in the same topic that I was, because it's hard to impose your topic on them. I think you have to be giving them something in order for a primary care, especially if it's not an academic center, if this is like a private primary care clinic. And the second thing is to, and you may already know this, but to really consider the flow of the clinic, because the thing that will turn them off the quickest is if you're going to make their lives harder in any way. And so even though there's great research that does make their lives harder that you could do down the road, when you're an early career person, it's good to kind of come up with ideas that don't impact the clinic and that they get something good out of. So I did one study once on screening and basically had parents complete some questionnaires while they were in the waiting room. It didn't slow the clinic slowed down at all, and at the end of it they got this really cool report back from me that gave them a lot of information about their clinic that they didn't actually know, and some stuff about their patient population since they weren't screening universally for behavior problems. So I would say those two things, like a champion and then finding a way to be not invasive at first and giving them something out of it initially, and then when you kind of build that relationship you can do a lot more interesting things.
Wonderful. Thanks, Tina. So looks like we're close to being out of time. I'd like to again thank both of our speakers today, Dr. Polaha and Dr. Studts. Their email addresses are on the slide ahead of you or in front of you. And in closing, I'd like to remind everyone about the upcoming CFHA National Conference in Washington, D.C., October 16th through 18th. From fragmentation to integration, a AAA imperative. Registration is live. Our early bird discounts end in about a month, so we'd encourage you, if you're thinking about joining us in Washington, D.C., that you go ahead and register as soon as possible. We're looking forward to a exciting conference. We will actually have a session, a plenary session from Dr. Russ Glasgow and Dr. Deborah Cohen on dissemination and implementation. So we're excited about that, and we look forward to seeing you all there. Thank you again, everyone, for joining us today.